Hello, everyone, and welcome to the PAPERI Bright Mind Series, held in recognition of International Childhood Cancer Day, ICCD 2026. This series brings together voices from different disciplines and regions to highlight how research, clinical practice, and health systems can work together to improve outcomes for children with cancer. I am Wafa Rashid, founder and chair of Pan African BGS Education and Research Initiative, and I will be your host for today's session. Today, we are honored to be joined by Professor Suparno Chakrabarti. Professor Suparno Chakrabarti is a leading hematologist and transplant physician, currently serving as Principal Director of the Action Institute of Bone Marrow Transplantation and Cellular Therapy at Action Cancer Hospital, New Delhi, India. He trained in India and the United Kingdom and is a fellow of the Royal College of Pathologists in Hematology, London. His clinical and research interests include haploidentical hematopoietic stem cell transplantation, natural killer cell biology, post-transplant immune reconstitution, transplantation tolerance, and post-transplant infections. Professor Chakrabarti is widely recognized for advancing transplant and cellular therapy programs in India and contributing to the global development of equitable bone marrow transplantation services. We are very grateful to have his perspective as part of ICCD 2026. Professor Soprano Chakrabarti, thank you very much for joining us today.
Yeah, thank you. Thank you so much. It's a pleasure to be here.
Thank you. And we have uh, an important discussion about bone marrow transplantation. So let's start with pediatric bone marrow transplantation landscape in India. My first question, from your perspective, how has pediatric hematopoietic stem cell transplantation evolved in India over the past decades?
Um, it's a very interesting question because when you ask about the past decade, I would say that a lot of things have evolved in the global field of transplantation in the past decade as well. And India has been sort of following the leads of the global transformation in the field of transplantation. Um, so to start off, in India, the major indication for bone marrow transplantation in children is actually non-malignant, which includes diseases like thalassemia, sickle cell anemia, and aplastic anemia. So they comprise the major proportion of transplants for children. Now, coming to non-malignant, malignant diseases, um, it is interesting that globally the indication for transplant in acute lymphoblastic leukemia, which is the major cause of cancer in children worldwide, has markedly reduced over the last few decades, and this trend continues. So in India also that trend remains the same. And at the same time, in diseases like acute myeloid leukemia, the indication for transplantation has increased. Although, say, for example, out of 100 patients with children with blood cancer, around 10 to 20 would be AML or acute myeloid leukemia. But the indications on that front have increased. So, I would say overall, the non-malignant diseases are dominating the field of pediatric transplantation, and the shrinking indication of transplant in children with ALL, along with increase in transplants in AML. Now, what has actually, happened is that the shift of transplantation from being dominated by match related and unrelated donor to haploidentical transplants. Again, this is a global trend, which it has been very much the scenario in India as well. So haploidentical transplantation has become more and more available, and it has been more and more refined. The mortality, morbidity of transplantation has come down. So everything put together, I see that in the field of pediatric transplantation, there has been a sort of shift from being a matched donor dependent transplantation field to a mismatched donor transplantation, which is gradually taking over.
Thank you. So, what are the major gaps that still exist in access to pediatric bone marrow transplantation services in India and South Asia?
See, I call it as the three A's. So the first thing is awareness. The second thing is access, and the third is availability. So when it comes to the awareness about transplantation, now at a primary level, primary physician level, at the level of the patients and their families, this awareness is still grossly lacking. That when a patient would require a transplantation, and if they require a transplantation, how to go about it. So in India, there's it's a tiered system. So you have a tier 3 city, you have a tier 2 city, you have a tier 1 city, and you have the villages. So if you put the villages and tier 4 city, tier 3 city, the awareness is still grossly lacking. Now tier 2 and tier 1, the awareness has increased. But even then, the access is obviously a problem. The access is not just a physical access, it's a financial access. And the third thing is, of course, the availability of donors. Now, even though I said that haploidentical is more and more popular, more and more available, but even then, at the level of the large part of pediatricians or pediatric hematologists, it's still perceived as a very high risk procedure and definitely not offered to patients where a transplant could have made a difference. Say, for example, someone has an acute myeloid leukemia, high risk in CR1, or acute lymphoblastic leukemia, MRD positive in CR1, where a transplant would actually improve the disease-free survival by 10-20%. There, it is discouraged because of lack of matched family donor. And when the patient has a relapse, especially if it's an early relapse, the outcome becomes extremely poor. So this gap, you can call it, of the understanding and awareness of when exactly to do a transplant and how to balance the risk and benefit of a mismatched family donor transplant or a haploidentical transplant in that scenario is still a work in progress.
Absolutely. Now let's move to another important issue, haploidentical transplantation and innovation. You have significant expertise in haploidentical hematopoietic stem cell transplantation. So how has the haploidentical transplantation changed the accessibility of curative therapy for children in resource limiting setting?
So I would put it in perspective in the sense that when I moved to India in 2009 from the UK, the dominant transplant scene in the UK or Europe was matched unrelated donor transplant. So around 20% would get a matched family donor transplant, but 80% almost would have a matched unrelated donor because the Caucasians have a very conserved gene pool, and for them to get a donor from a matched unrelated donor registry was not too difficult. So majority had it. So haploidentical transplant in the UK was not very common in 2008, and haploidentical transplantation across the globe was neither. So that was when I had moved to India to start a transplant program. And what I found was that, as would be the scene if you don't have a matched unrelated donor transplantation opportunity, because Indian unrelated donor transplant registries had not developed at that stage. And there was dependence highly on NMDP or DKMS or worldwide bone marrow donor registry sort of thing, where not more than 10% of Indian patients would get a matched donor. So in that scenario, I had to conceive of how to go about doing haploidentical transplantation. In India at that point of time in 2009, this program was developed in 2010 with the help of a very good friend of mine, Professor Franco Aversa from Italy. And I was greatly helped by Professor Paul O'Donnell from Seattle at that time. He actually initiated the type of haploidentical transplant which we are doing all over the world today called a post-transplant cyclophosphamide-based haploidentical transplant. So when we started with their help in 2010, we had to go through a lot of difficulties in the sense the proof of principle that, okay, so you're doing a transplant, does the transplant work? That is, you are getting engraftment, the patient is getting the donor bone marrow cells sitting inside the patient, and is it working? The answer is yes. We were getting it in, say, 10 out of 10 patients. But when we were doing patients with high risk malignant diseases, the disease used to come back pretty rapidly. So even after going through the procedure, the disease relapse was not averted. That is the main point of doing the transplant, which was not served. So we had to innovate at that stage. We came up with a concept of giving donor lymphocyte infusions very early on after the transplant. And that sort of worked, that the chances of relapse from, say, 80% was reduced to something in the range of 40-50%. But still, that was not enough. And that is where we came up with an innovative concept of using abatacept, which is a T cell co-stimulation blockade. The other way of doing transplantation, if you're not using post-transplant cyclophosphamide, is to use T cell depletion of the graft. So the bone marrow cells or the peripheral blood stem cells, we selectively take out the T cells to avoid graft versus host disease. And that is an expensive procedure. That's a very expensive procedure. And that was the standard way of doing it before the post-transplantation cyclophosphamide concept came in. Now, the way post-transplantation cyclophosphamide works is that in the patient, when we are giving them high dose of chemotherapy and or radiotherapy and depleting their own stem cells, good and bad, so we are giving the donor stem cells along with the T cells, everything. Whatever we collect, we give it. And traditionally, before that, we give immunosuppression so that the donor T cells do not cause reaction in the patient called graft versus host disease. And at the same time, the patient's T cells or immune cells don't reject the donor marrow. So an immunosuppression like cyclosporin, methotrexate, etc. were given before you give the cells from the donor. So that's a standard graft versus host disease prophylaxis. Now, what happens with post-transplant cyclophosphamide is that you are not using an immunosuppression upfront. You are just giving the cells to the patient. And what happens is the cells which are supposed to identify the patient's cells as foreign and are going to react are allowed to react. And whatever residual cells are there in the patient which would react against the donor cells are allowed to react. Now there is an eruption that takes place within the patient's body where both their cells are reacting against each other. And these cells sort of explode within the patient's body. When these cells explode, they lose an enzyme in their own cells. When the cells are rapidly dividing, they lose an enzyme called aldehyde dehydrogenase. Now, the cells which are quietly sitting inside our body, like stem cells, like cells which are not fighting with each other, they have very high amount of aldehyde dehydrogenase. So this is nature's way of protecting us from toxins. In this case, cyclophosphamide, all chemotherapy drugs are, toxins in a way. They are toxic to the cells. So the body has a natural mechanism to prevent it. So this enzyme prevents cyclophosphamide from damaging the cells. But when they are rapidly dividing in response to something, they lose this enzyme. So the cells which are fighting with each other, they die on exposure to cyclophosphamide. And that was the concept based on which 3 days after giving the stem cells, high dose of cyclophosphamide was given to the patient to kill the cells which would cause reaction within the patient and patient cells which would reject the graft. It worked beautifully worldwide. It has been shown now that it works wonderfully in haploidentical transplants to achieve engraftment and have much lower GVHD than ever before. But what we found was that in this context, even though we are having all these things, okay, the disease itself, the malignancy, the cancer, the leukemia is coming back, especially when they are, very high risk of, when they're at a very high risk of relapse. So we introduced a drug called abatacept, which basically numbs the T cells which are going to react. They're not killing the T cells. Along with post-transplant cyclophosphamide, and we use donor lymphocyte infusion along with abatacept, which is a very novel concept. I mean, this we started in 2015, and we had pretty dramatic results with our outcome improving to 70-80% with very high risk leukemia. And we have, developed this protocol over the last 10 years. And recently in US, they have adopted this protocol with their own sort of modification and name. But the basic skeleton of the way we have been doing transplants is now happening in United States as well. So this was largely developed to reduce graft versus host disease and yet achieve an effect to prevent the leukemia from coming back or controlling the leukemia. So that is what we have done or achieved. I mean, there are numerous publications on this, and we have reviewed it as to how and why we have developed this protocol. So I would say that this has been largely a game changer as far as haploidentical transplant is concerned in our hands. And we are eternally grateful to, the Almighty to give us this opportunity to make a significant shift in the way haploidentical transplantation is done worldwide at the moment. At the same time, this approach without the donor lymphocytes we have used for thalassemia, sickle cell anemia, or aplastic anemia, where the main aim is to get the cells in the patient, make them work, and not have graft versus host disease. So there in those patients, our success rate is in excess of 90%. So overall, this approach has worked wonderfully, and I'm pretty sure that in due course, this will be adopted globally at a much larger scale with availability of abatacept being more and more across the globe, and adoption of this concept, understanding of this concept, haploidentical transplantation will become much easier.
This is wonderful. So, what are the key challenges in implementing haploidentical protocols safely in low middle income countries?
See, the biggest problem is obviously the cost. cost is a major factor. Now, if I come to non-financial aspect of it, the infections. I mean, you have a period after transplantation where the patient does not have an immune system. And in a sort of HLA mismatch situation or haploidentical transplant situation, this is multiplied several fold, means the chance of an infection is much higher because the duration of the bone marrow being empty is longer. You are getting a mismatched HLA mismatched bone marrow cells in a patient, which takes at least 4 or 5 days more to start working. So the duration of this complete empty bone marrow period, or the absolute neutropenic period where there are no granulocytes or neutrophils to fight infections, is what is critical in the outcome. Now, if that was only the case, we could have still dealt with antibiotics. But as you might know, that in India and other adjoining countries, there is a major problem of multi-drug resistant bacteria. I mean, it's getting into a global problem, but in India, it's an acute problem right now that 80–90% of the hospitalized patients have multi-drug resistance, to the tune that they're resistant to the best possible antibiotics. So to handle this period with multi-drug resistant bacteria in the system is a big challenge. If this can be taken care of, I think any form of transplantation would become easier. And if this problem gets more acute and gets, it bursts on its seams, means like antibiotic resistance gets a bigger problem, then doing a transplantation will be extremely difficult. So if I summarize, the key challenge of doing a haploidentical transplantation, apart from the finance, is the multi-drug resistant bacteria in the setup that we have right now. Now, apart from that, if we do a matched donor transplantation, the follow-up and the chances of complications after that versus having a haploidentical donor transplant and the chances of complication thereafter, there are 2–3 folds to 10 folds higher. So to manage patients post-transplant in a very methodical way to prevent these complications and to manage these complications as they happen is also a big challenge. So haploidentical transplantation does not end during the, when you're out of the four walls of a bone marrow transplant unit. It's just the beginning of the journey. Like, we follow our patients very meticulously, regularly for the first 6 months to 1 year. And even after that, in the first 2 or 3 years, we see repeated infections happening. So we are constantly on the vigil to, take care of the patients in these situations, because we cannot afford to lose a patient who has been cured of the leukemia, has gone out of the first 6 months to 1 year, but then out in the community getting a respiratory viral infection and succumbing to it. So there is a whole protocol in place for our team where we, constantly put these patients on a vigil until their immune system reaches a stage where they can be safely out in the community. And such infections would not pose a risk to the life. So it is a long haul, a long drawn battle. In a matched donor transplantation, I would say 6 months is a time by which things start getting better. But in a haploidentical transplantation, it's longer. So all of them put together, I would say it's extremely challenging for the team of physicians, nurses, and paramedical staff to implement all these protocols and keep patients under follow-up and If they're coming from a distance, how do you manage that in collaboration of a local team? So all these things have to be in place if we are to do a haploidentical transplantation as a program, as a successful program in children who we are expecting to cure of the leukemia.
Thank you so much for your informative answer. Now, how do you see the role of natural killer cell biology and cellular immunotherapy evolving in pediatric malignancies?
So this has been the sort of, the backbone of our work in malignant diseases. So our exploration of curing malignancy has been through natural killer cells. Now, just to say briefly that we get cancer because our immune system fails to control it. Otherwise, cancer is killed in the bud by the immune system of a human body. So at many moments in a day, as a cell is turning rogue, potentially cancerous, the immune system immediately recognizes it and clears it. So once that system fails, we develop cancer. We develop leukemia or lymphoma. Now, when we are trying to get the disease under control with chemotherapy, etc., we are never killing off the last tumor cell with any amount of chemotherapy or radiotherapy. This is a very famous saying by Professor Shimon Slavin that we can never kill the last tumor cell with any amount of chemo or radiotherapy. You have to kill the person to kill the tumor, last tumor cell. So the last tumor cell is always taken care of by our immune system. And traditionally, it was thought that the T lymphocytes were the ones doing the job. Till in the 1990s, the Italian group led by Franco Aversa, Massimo Martini, they showed that the natural killer cells can do the job as well as T cells if you just take the T cells away to prevent T cell mediated reaction or graft versus host disease in the patient following haploidentical transplant. The natural killer cells own the field, they do the job of clearing of the leukemia. So based on that work, over the last almost 12, 13 years, we have been working on natural killer cells. And we have sort of understood that there are, certain type of natural killer cells. So natural killer cells are basically cells of the innate immune system. Means like neutrophils, they're born and they die. They're born and they die very rapidly. Like the monocytes, macrophages, they're born and die. They don't live very long. So that was an existing concept when we started the work. But we identified, along with a few other groups across the globe, that there are a group of natural killer cells which remain in our body, which stay back. And interestingly, this sort of natural killer cells, which we now call memory NK cells or adaptive NK cells, which behave very much like T cells, are triggered by cytomegalovirus infection. So if the human body gets exposed to cytomegalovirus, these natural killer cells would start developing. Now, cytomegalovirus in an immune competent person is not a problem. It is a subclinical or asymptomatic infection. It stays within the body, it doesn't die off, it stays quietly within the body. And every exposure to cytomegalovirus, one way or the other, expands these cells. And these cells persist in the body, they fight viruses, they fight leukemia. And we have explored these cells over the last, 7 to 8 years. We have been working on these cells, and we have found that in patients where these cells are coming up in good numbers, leukemia cannot come back, or 9 out of 10 cases, they will be cured of the leukemia. It is that dramatic an effect. So where do these cells come from then? I mean, what's the source of these cells? So the source of these cells are the donors. So there we came up with the whole concept of we have to select the right donor for a particular leukemia, which donor will have this right quantity, right type of these adaptive NK cells. And this is something we have been working on. And we have, after doing this sort of donor, precision donor selection, we have found that if we get the right donor, irrespective of the type of leukemia, the survival is in excess of 90%. But if we are doing it from the wrong donor, then the survival is 30%. So it's all driven by the donor cells, how well we have identified and implemented the donor cells. The second approach that we have taken is based on the clinical work on abatacept. We have recognized that abatacept has got a salutary effect or promoting effect on the natural killer cells. It increases the capacity of this killing of leukemia. It increases their nature by making them more adaptive or live longer. So we have developed a natural killer cell product. We call it Abani 15, which we have now used in 12 patients. And this, the development of Abani 15 has been largely led by my student and my junior colleague, Dr. Mehak Agarwal. So the results are fantastic as of now. I'm not saying that's the end of the road. There is still a lot maybe to do, but it looks very, very promising because we have dealt with patients who have come with relapsed leukemia with 200,000 white cell count and not responsive to chemotherapy, where we have used these natural killer cells along with a haploidentical transplant, Abani 15, and produced miraculous results. So which we find it difficult to believe when it happened in front of us. But there is a lot more in nature than we realize. Right now, the trend in the world is to engineer everything. Because we have the capacity, we want to engineer everything to our liking. I would create a cell which would create a X cell. I would create another cell which will create a killer Y cell. But nature has engineered a lot of things for us. We have to understand that. And if we can utilize the laws of nature to attack the enemies created by the nature within the system, we have the best chance of dealing with things without causing too much harm. So that's my take on it.
Thank you so much. Now let's move to another important part, immune reconstitution and post-transplant infection. As you said, post-transplant infections remain a major cause of morbidity and mortality. What are the most critical barriers to improving outcomes in low middle income countries' transplant programs?
So as I already said, that infections are the major problem in these sort of transplants, and they are mostly multi-drug resistant. So in the first stage of transplantation, where we have no neutrophils, no monocytes, no lymphocytes, we have destroyed it all to get the donor cells in. And the donor cells take 15, 20, 30 days to start working. In that period of 2, 3, or 4 weeks, we are completely vulnerable. As a patient, we are completely vulnerable to any attack by any bacteria. And if it is multi-drug resistant, we are 100 times, 1,000 times more vulnerable because of lack of appropriate antibiotics to deal with it. Now, what we did in that situation when we first faced this problem with a very high mortality, 30% mortality because of infections, we started using donor neutrophils. Neutrophils, as I said, are very short lasting. They live for 2 or 3 days. They would die off. So we plan to give multiple infusions of donor neutrophils or donor granulocyte infusion, as it is called, before the infection sets in, to tide over this period where there are no neutrophils or no cells in the body. And with this approach, we have thankfully been able to address the initial problem of multi-drug resistant bacterial infection and deaths happening because of that. But then comes the next phase where you have got your neutrophils back, but you don't have your lymphocytes. And that is the stage when viruses start attacking the body from within. Cytomegalovirus, Epstein-Barr virus, adenovirus, and from without the outside, all the whole host of respiratory viruses, influenza, parainfluenza, you name it, there is all. I mean, you are just surrounded by these viruses at that time in the most vulnerable period. So a very strict isolation within the system means you don't go out and invite trouble. So that's our advice to the patients, that stay out of crowd, wear a mask, wash your hands, like all the COVID protocols that COVID has actually made our work easier. We just tell patients now that just follow the COVID protocol. So that way you at least try to prevent the infection viruses you are getting from without. Now, what happens from within requires a vigilant monitoring. We monitor CMV, EBV, adenovirus, and try to prevent them from getting to a stage where they can cause mayhem in the patient. Now, how do we do all these things in a resource-limited setting? So these monitorings are largely based on polymerase chain reaction of PCRs. Now, PCRs are not very expensive tests at current time. They can be developed in-house. There are kits available. All it needs is doing it at a regular interval to detect any problem that's coming up. It is more because of not doing it than the cost that the problems happen. So once it happens, the cost of antiviral therapy is, spirals out. So the main thing here is prevention. Prevent getting a bad respiratory viral infection, spread the reactivation, stop the reactivation of cytomegalovirus or Epstein-Barr virus very early on so that they don't become a problem. So the next phase is spent on that phase. And mind you, in a humid tropical country like India, adjoining places, also in Africa, I would say, fungal infections are a problem. Especially in India, there's a lot of pollution in the winter season, and we get a lot of patients coming in with fungal infections. So it's a constant battle with pathogens around us till the immune system develops to a stage where it can take care of itself to an extent. So prevention, monitoring prevention, that is the way in low middle income countries, rather than putting a patient on a drug which would reduce the chances of getting infected. Because a constant, exposure to drugs, I don't agree with, because it again leads to resistance of the bugs to that particular drug, and it increases the cost pretty, steeply. So my approach in a LMIC is to prevent, monitor, and treat at the earliest possible time.